All right.
It's spilled already.
So welcome everybody. I literally just put my hair inside of a cocktail, turning on.
It's a courageous act to start
It's a
with.
courageous act, exactly.
Yeah.
So welcome to Cocktails and Courageous Conversations, where cocktails are optional and courage is guaranteed. I am here together with the amazing Dr. Patricia Robinson and the amazing Dr. Kirk Strosahl. So here's the thing, we're at a venue in Copenhagen where Kirk and Patty have been training us all day. We have the camera there. There might be light in our eyes. We only have one microphone and we're like, making it work.
Making
it work.
And be prepared for flashes from subway trains going by.
Exactly. Be prepared for flashes and the
Be
sound
prepared for
might
almost damn near anything.
You can be, and I've
Yeah.
already put my hair inside a Cosmopolitan, so what's not to like.
There's no, you can't go any lower than that.
You can't go any lower than that. And also, I am monitoring if you have any questions for us, please put them just below here, and I'll make sure to that we ask Kirk and Patty these questions. And also, whether you're with us live, and I see there's a lot of you already, whether you're with us live or watching this afterwards, come in and say hello. We want to know that you're here. Let me see if I can actually see who's here. It looks like Margot is here. Hello. Patrick from Sweden is here. I see that Ilse is here from Norway. Marie, Raquel is here. Love that you are here, guys. My glasses are like, whew, we're so warm here. All right, guys, why don't you introduce yourselves and tell people who you are? I'm guessing that most people, everybody will know who you are. In case somebody missed it, Patty, do you want to go first?
Yes, I'm Patty Robinson, partner of Kirk Strosahl for many, many years, and mother of 3 daughters and mother of 3 dogs. And I am living a lot these days by the Neahkahnie Mountains and the Nehalem River on the Oregon coast in the United States.
Yeah. What do you work with?
What do I work with?
Yeah, what do you do for a living?
Oh, yes, my work, yes. And I work quite a bit. I have...
That's an understatement.
Sometimes she does a little work.
Yeah,
Yeah.
I do a little work. Yeah, so I have for the past 15 years been a trainer and technical assistant to healthcare systems and to groups of individuals wanting to improve healthcare primarily. So it could be a mental health group that's wanting to learn about focused acceptance and commitment therapy. It could be a healthcare system or a group of systems that are interested in improving healthcare by integrating behavioral health services into general practice settings where people are more accessible.
Love that.
Behavioral health providers are more accessible.
And much needed work. Just before I want to give you the opportunity to introduce yourself, Kirk, I just want to say hello also to Sheila is here, Annika is here, Diana is here from Romania, Francesca, my friend from Italy, in Finland, Else from Bergen, Margot, cheers, Johanna Moraine is here, Christina is here, Manabu Yoshimoto is here, Michaela is here, Rita is here, Marie is here, Philip is here, Alexandra Shapcrow is here, Pernille er med, Sarah Habiba is here from Turkey. How amazing that you are here, guys. Thank you so much for that. Kirk, would you like to introduce yourself?
Yeah.
Yeah. Who are you?
That's what I often ask myself when I look in the mirror.
Like, who's that guy?
Yeah, what's that? So I'm Kirk, and I'm a co-founder of ACT and partner of Patty, the Dragon Lady of Fact.
The Dragon Lady of
Yeah,
Fact. Yeah.
And what do I do now? I'm hanging out on the Oregon coast near the Neahkahnie Mountains at Nehalem Bay. Sometimes I write books, sometimes I go and train, but as I like to tell people, I don't have to get up and be somewhere at any particular time in the morning, which was my entire goal in life.
Wow.
I wanted to return to teenage years when we were in summer vacation
Yeah.
and go on permanent summer vacation.
I love that.
Yeah.
So, so guys, if you have questions, again, just put them here in the chat. I'll make sure to monitor the chat. And I have a lot of questions for you guys. So one question could be, and feel free either one of you to answer and to supplement. Both answer. You get what I say. What is focused act? I get that question a lot. First of all, people ask, what is focused act? And the second question, I know I'm asking two questions, and these are large questions, but many people ask, can you use focused act? Like, can you only use it in a 20-minute, one single session? So if you could answer that, like, what is focused act and where do we use it? When?
Well, focused act is a condensed version of ACT. And what I mean by that is instead of rolling out concepts one session at a time, we roll up the whole model and present it to the client in the first visit and then in every visit thereafter. So we don't ever have the problem of, geez, I was going to start introducing, mindfulness to this person next time they came, but they didn't show up. We kind of roll out the entire psychological flexibility model in the unfolding conversation. And among other things that are kind of specific to fact, we always start a behavioral experiment, even in the first session. So there isn't a session where you just assess people and then tell them when you come back for the next time, we'll actually start treatment. Treatment starts in the first 2 minutes of the first session. So we're trying to actually get people moving in their lives at the time when they're most likely to change, which is when they first come in seeking help. That's when they're going to be the most likely to change. And so we're going to capitalize on that opportunity to the maximum extent. In a broader sense, the guiding philosophy of FACT is you make the most of every session, assuming that it could be your last session with the client, that they may not return, for reasons that have nothing to do with you or the therapy. It's just hard for people to kind of stick with therapy. We know that. And so we try to create almost a series of single session interventions, even though they're linked, and if somebody comes back, we obviously know what they did last time and we can talk about that. But the functional philosophy is that every session could be the last, so every session has to be a standalone intervention. It doesn't have to be 30 minutes. So that was another aspect of your comment. We do it in 30 minutes because I think the longer you sit around and talk with people, the more danger you create for yourself. And keeping things simple and direct and immediate and sort of behaviorally flexible is far preferable to languishing around in languish. There's a reason they call it languishing. It's LAN, language, right? So the danger of going longer than you need to is that you're just going to create more problems for yourself and you're going to lose focus. So if people do 30-minute visits, that's fine. If they do 60-minute visits and your guiding philosophy is this might be the last time I see somebody, I'm going to make the most out of this session. They're going to leave here with a behavioral experiment. That's very consistent with the model. So time doesn't govern, you know, oh, gee, I'm seeing people for 45 minutes, so I can't be doing fact.
Or
That is-
even I'm seeing people for maybe 6 weeks or 6 months or 6 years. You can still do focused
And
act.
you can
Like
do
you can still
focused act.
treat every session as if it was the last or a single session.
Yes,
Yeah.
it's the focus on, let's get something done today
Yeah.
that will have some kind of meaningful impact on your life after
Yeah.
you leave here today.
It's very focused on change. I love that what
Change.
you're saying, that within the first 2 minutes there's a focus on like what are we going to change
What are
here?
we going to change?
Yeah.
If you don't change anything, you're going to keep getting the results you're getting.
Yes. Yes.
Yeah.
Just to add a little bit to that, when I was in practice, I would see, maybe I'd see somebody when they were 12 years old, some problems with peers, and then for 2 or 3 visits, kind of helping them with their psychological flexibility at that time. I might see them again in high school, maybe experimenting with drugs and alcohol and experiencing some problems. And then I might see them again 3 years later for maybe first pregnancy and kind of wanting to start to anticipate what it really means to be a parent and trying to get in touch with their values at that point. So it's really about being there for a large number of people in a highly accessible way and teaching the skills needed at that moment to help them expand their psychological flexibility to meet the challenges in their life at that time.
Yeah.
You know, guys, life is one damn thing after another.
Oh, cheers to that.
Your job as a human is to make sure it's not the same damn thing.
Life is one damn thing after another. Our job is to make sure it's not the same damn thing. Oh, that is clever. That is wise. We're enjoying a cosmopolitan and a glass of red wine after a full day of training here, and we're so happy that you're here with us. I just wanted to give a shout out also to Singapore. Sukai Liani, Dolly is here, Laurie is here, Carolyn, Angelina, Katerina, Ancha, Pia is here. Again, thank you so much for joining us, and make sure that you put your questions here now that we have, and no pressure. I will refer to these people as gods themselves, so no pressure. One of the things that I wanted to ask, which may not be particularly about focused act, but you and I earlier at lunch, Kirk, I said to you that you are one of the most, in my humble opinion, I see you as one of the most skilled, the both of you, as the most skilled practitioners in the world, and I just love to watch you guys work. And at this conversation, I was alone with you, Kirk, and you said that it wasn't for you. It wasn't always like that. And I wanted you to comment on that, because we see so many practitioners out there. I see so many practitioners, and I hear so many say, I might not be good enough. Like, we should take more courses, we should take more classes, we should learn more, which I definitely believe in. We're act trainers. We want people to get training. And also, I see so many of us suffering from imposter syndrome, thinking that we're not good enough and that we might never be as good as Patty and Kirk. And what you said to me during lunch was just so moving, where you told me about your own journey from where you started until where you are today, where it's a little bit more fluent and people are like, oh my God, God himself. Would you be willing to tell the group about this?
Yeah, sure. I started out, I think, with the best of intentions as a therapist, but I think I was relatively ineffective. I was very protocolish, right, in my approach. And I had a view of the world that, or, you know, what people needed that I thought they had to fit into it. And a lot of that was CBT, actually. And my roots are sort of raw behaviorism and then CBT sort of thrown on top of that. But the whole protocol model, and there's sort of a certain number of sessions that people need, and I think my regret looking backwards is that I left a lot of people who could have benefited. I did not benefit them because I was busy following my own rules and the rules that I had been taught about how things were supposed to be. And, that's just part of the journey, I guess. I mean, and I can't actually say there was a turning point for me, really. I mean, that I was aware of. I'm making a move here, but I do think kind of moving into the ACT universe, being part of that creation, just had that impact of I can give up the idea that people have to fit some kind of pre-existing, preordained reality, and I can just meet people where they're at. And I can think of hundreds of clients that I screwed over. I mean, not in an intentional way, by not adopting that posture, that they just didn't connect with what I was doing, and then, therapy ended the way it ends when you're not connected with people. So I think everybody's on a journey when they're learning to be a helper, and at different rates of speed, you discover the things that work magic in your hands. And for me, honestly, it probably wasn't until I was about 45, something in that. I'm 70 now, 70, coming up older than dirt. Let's just put it that way. But it was quite a ways into my career before I felt like that I got it. And it wasn't like I got it act-wise. I got it, there's something fundamental about being there for people that is not about models, right? It's just about being present, being human, being able to talk about things in human terms, not labeling everything as sort of an example of a psychopathological process. Yeah. A lot of what released me was letting go of psychopathology.
Yeah.
As a meaningful way of thinking about my work.
Yeah.
And starting to think about suffering and compassion and natural human processes that people are doing with the best of intentions, and that opens up a whole bunch of possibilities.
And it sounds like your own approach started to be more flexible and more about workability rather than about protocol.
Yeah.
Yeah.
And giving up the idea that people actually had disorders.
Yeah.
That was my early training, was just full of disorder-specific concepts and trainings, and that's all you read when you were studying clinical psychopathology, was disorder-based thinking.
Yeah.
So, it was kind of an indoctrination, and it took a couple of decades just to shed that. And of course, I was a child of the evidence-based care revolution in CBT. So everything that was happening, Barlow's work, Edna Foa, these people worked with disorders.
Yeah.
Right?
Yeah.
And these were the gods of that generation. And, they were all very, very successful, and they got lots of grants, and it looked, for all intents and purposes, like all that was true.
Yeah.
So, there was a lot of what we call tailwinds.
Yeah.
Right? Making it easy to think that that's the way it's supposed to be.
Yeah.
And, so it's hard to wake up when you've been pushed along that path for that long. And everybody will have their own tailwinds.
Yeah. So in all of what you just said, I personally find it very comforting to hear that, because this grew from a conversation you and I had at lunch about imposter syndrome or feeling like you're not skilled enough, and so I'm so interested in this because, again, I train people for a living, and I see so many skilled practitioners but feeling so insecure and being actually held back by insecurity and not willing to, being unwilling to practice and to expand and to experiment. And so it actually gives me a lot of soothing to hear that you too, like Kirk Strosahl, has had a journey of maybe not being proud of everything that you've done. Yeah, which is, of course, logical to all of us, but we might look at people like yourselves and go, they have got it and they've always had it.
Yeah, my problem was I was too secure.
Yeah.
I should have been more insecure.
Yeah.
Right?
Yeah.
The veil of artificial knowledge
Yeah.
made it look like the only person that has the problem here is the client. They're not benefiting, and if they saw the light,
Yeah.
they would benefit.
Yeah.
So, that's being too secure,
Yeah.
right?
Yeah.
The other end of the continuum is just as dangerous as imposter syndrome.
Exactly. Because we want flexibility,
Yeah.
and tracking of workability. One of the things that strikes me when I look at the way you guys work is that you care so much about your work, you care so much about your students, you care so much about your clients. So I wanted to ask you, Patty, now, what is it that you're, so clearly you're a very passionate woman. What is it that makes you so passionate about your work? What is it that sparks your fire? Can you say that? Sparks your fire?
Lights your fire.
Lights your fire, yes.
Yeah.
Come on, baby, light my fire.
Come on, baby, light my fire.
Yeah.
Well, I think, early in my career, I was interested. I was a feminist. I was interested in social justice and equality, and I was, interested in Buddhism. Yeah. So all of these things were kind of things that brought me to fact. So I started and I questioned a lot of the prevailing psychotherapy because I thought there was a lot of politics and power kind of embedded in the structure. So I kind of carefully questioned that, but I always had a healthy amount of curiosity and skepticism, although didn't often feel safe about voicing that. But I could take it into science, and I had some wonderful opportunities to kind of work with scientists that were grant getters and really were interested in the possibilities of taking a public health approach and emphasizing function and brevity and taking behavioral science into venues where it would have a greater reach. So that just aligned so nicely with my passions and helped me further define, what I really wanted to do and to kind of follow my passion, follow my bliss, so to speak, and move out of research into seeking, opportunities for model development and really changing how behavioral health services are delivered. Having a part of that has just been a real honor. So I left my research team and went to rural healthcare where there were very few behavioral health services for people, and worked in primary care. So that perspective of health is for everybody, and we can come closer. We can come closer to that.
Yeah.
Yeah.
And you do, today you travel a lot, don't you?
Yeah.
Yeah, I know New Zealand, for instance, isn't that one of the places that you are a lot?
Yeah, the New Zealand started with a proof of concept study in December 2016, looking at using FACT by people trained to work in ways consistent with the primary care behavioral health model. That's a high integration model that brings the behavioral health provider into primary care to work as part of the team, the medical team, and to make delivery of holistic care more attainable. I've written 2 books on that and am at work on a 3rd edition with Jeff Reeder on that. And that was an awesome, kind of realization that, we need to figure this out. We need to go beyond research studies that don't really tell us exactly what to do. They tell us if you were doing a research study and you did this with this group of people, you might get this result, and we needed something different. So in New Zealand, they wanted to make healthcare better, and they wanted to make it more equitable. And so in this proof of concept study, involving 5 different clinics, one of the outcomes was a finding of health equity where Maori, Pacific Islanders referred to a behavioral health provider access services at the same rate as the Europeans. And the clinical outcomes of Maori, for example, were slightly even better than the overall sample, so like 74% improving compared to 71% in the overall sample. So, yep, that was kind of the peak experience in my career. And because then with that finding, as well as, other findings that were very favorable, they moved to a national study, moving to multiple sites across the country in different settings, and the findings were so compelling 9 months into the national study that the government said, stop the research, we're funding this for the whole country. So we're several years into that. I know, it was very amazing. And the great Jacinda Ardern, let's toast.
Let's toast.
Female Prime Minister.
Oh, yes.
Yes.
And also Kirk and Patty.
Young.
Also Kirk and Patty, like the impact you're having in this world is just like mind-blowing. Thank you so much for sharing that, and thank you so much for allowing yourself to shine. I'm very proud of you. Here's one. Hello from Helsingborg. Barbara's here, Linda's here, Cecilia, Ulrika. Here's one from Taylor saying hello from Indiana, USA. Curious about in what circumstance you would recommend using ACT over FACT. Is there ever a time that is more suited to use the longer approach to ACT over the briefer FACT, in your opinions? What an excellent question. What do you say to that, guys?
Well, one thing I would say is I'm not really sure that there is a specific guideline. There's so many factors involved, so I think it starts with patient preference and patient resources. If a patient has the resources to access ACT therapy from an ACT therapist, and wants that, I think that's a person that should get that because it's very rich, it's wonderful, and it's effective with so many problems. FACT, I think, is a model that allows people that might not have the resources to pay for behavioral health services or even get there, or have an ACT therapist in their community, to access some support in growing their psychological flexibility, because it's situated kind of in a context where the person is more likely to be able to have access on a same-day basis and at a lower cost or at no cost often. And that doesn't require that much motivation for therapy per se. So I think it takes a lot of motivation for people to go into ACT therapy and stay for a while. Doesn't have to take too much motivation for someone to say yes. If their GP says, look, I want you to meet Patty. She's helpful to a lot of my patients. She might be available right now. And her services are free or cost very little. I think they'll be affordable. So that gets a lot more people. In that context, what we know is we're effective with about 90% of the people. 90%. Now, the people that are showing up to primary care include people with a lot of challenges that would maybe it would be helpful for them to have an ACT therapist. And maybe we can help with that transition, but maybe not. They may not be motivated. The resources might not be there. So I guess that's a practical answer, not based upon any kind of clinical, sorting by disorder, because in fact, and we see everybody and work as generalists that are committed to helping people go out and do something different in their life and see what happens, see if it works better for them.
Cool. Thank you for taking the time to answer that.
I hope that's clear. Let us know.
Let
if
us
that-
know.
Well, people got to remember
Clear as mud.
Yeah.
there's very little evidence or reason to believe that brief versions of ACT are less effective than longer versions.
Yeah.
And that's actually true for CBT, for behavior therapy in general. So, if you thought about why would I give somebody a longer version of something when the shorter version works just as well, the answer would be maybe I should start out with the shorter version and then see who doesn't respond and then transition to the longer version, right? And certainly from a capacity point of view, like if you give people a bunch of unnecessary treatment because they would have gotten better if you did it in 2 or 3 visits and you gave them 9, you've just burned 6 visits.
Yeah.
Right? And the system is already overloaded. It has finite capacity. And so from a system perspective, it would be much better not to separate ACT and FACT and say which one is which. But let's start with the principles.
Yeah.
ACT certainly wouldn't, you don't read anywhere in any ACT book I've ever seen that says you shouldn't optimize the impact of each session. They don't specifically talk about optimizing the impact, but if I said, hey, do you think you should try to get the most out of every session? I'll bet you there's 0 ACT experts who would say, no,
let's prolong
let's
it.
prolong it.
Yes.
Right.
Let's be ineffective.
Just going to say several healthcare systems that I've worked with have moved to having general practice be the front door for all behavioral health services. So with the other services being secondary, and they're really important and useful. The United States Air Force has, after piloting that and evaluating it, I think they did a great job of evaluating it, implemented it worldwide at military primary care clinics around the world. There's a lot of them. And they have found that more people are seen in both the specialty mental health or secondary mental health and in primary care by behavioral health providers working there. and they're seen for more visits, and also that they're able to see patients that would have never accessed a higher level of care, so to speak. So other systems I'm working with, like now pediatric system with 30 clinics, that's the way they are redesigning their service. So they have wonderful specialty behavioral health providers, and they are very useful, and you're able to build a stronger link. And I think that's what we need, is people coming out of their silos and working together, so that maybe somebody is with an ACT therapist for a while, make a lot of gains. How wonderful if that ACT therapist could kind of reach out to their primary care or general practice provider, introduce them to the person working at that level that's part of their team, so that they need a little booster, they've got it. It's easy. It's a win-win.
Love that. Love that. I'm going to go through the questions now so that we can get as many as possible, even though we could stay on these forever, couldn't we? It's so good. Here's one from Patrick, our friend Patrick in Sweden. He met you guys in a FACT course in 2019 when you came to Stockholm. And he's saying, are there any news? This would be, I believe, a brilliant opportunity to tell a little bit about, because I saw you at the WorldCon this summer in San Francisco talking about, tell us about your new passion project about crisis work.
Yeah, and this is actually with a psychiatrist from Sweden.
Yeah.
And I have kind of put together this model.
Yeah.
She's a neuroscientist who then cross-trained in psychiatry, and now she just got accepted into psychotherapy training. So she's gone a long way. That's a big circle. Let me tell you. From looking at PET scans and fMRIs to starting to be an emergency room psychiatrist, and then ending up being a psychotherapist in the Swedish system. So shouts out to her. Her name is Katrina Karlsson, who also lives in Stockholm.
Yeah.
Our model, ACT for Crisis Intervention, is coming out in a book.
Yeah.
That's being published by the American Psychiatric Press. Probably will be out early 2023.
Yeah.
It's actually in the proofing stage now at the publisher, but it takes 6 to 9 months to get things out from that stage.
Get the title, Kirky.
Oh, yeah. After months of silent retreat where no word was spoken. Have you ever written a book where you didn't have the title?
No.
Yeah. It's a real different experience.
I've
never written a book where I didn't have the title.
I can imagine.
Katrina wrote a book where she didn't have the title.
So what's the title?
Until the last minute.
Now, this is a cliffhanger. Before we give away the title, let's just cheer, and that people are going,
Cheer.
give us the title,
Cheer Katrina Karlsson.
Cheer Katrina Karlsson. You go, girl. Cheers to you. So ACT for Crisis, what's it called?
Learning, loving, doing. Acceptance and commitment therapy for crisis integration.
Learning, loving, doing. Acceptance and commitment therapy for
crisis integration.
Integration.
Yeah. We don't use the word intervention because that suggests that you shouldn't have a crisis.
I love that. That is smart.
A crisis is a decisive turning point in someone's trajectory through the universe.
Yep.
So we don't want to intervene in the sense of taking the crisis away from them.
Yep.
We want them to lean into the crisis and integrate themselves as a result of what they've gone through.
All right.
Yeah. And you do that through acceptance and engagement, right? Emotional acceptance, life engagement, and mediated centered around mindful being and mindful doing.
Yep.
So that's the short version of our CI model. The longer version is the very interesting approach that Katrina brought to the experience of human emotions, which is way too complex
Yep.
to talk about here. But
Yep.
you will find it fascinating if you read it, that emotions actually have a specific autonomic reference point and purpose with respect to brain survival.
Wow.
Yeah.
And something else new, Ricky,
Yeah,
I want to
yeah.
tell Patrick that I published a book called Basics of Behavior Change in Primary Care in 2020. And so that's a book I wrote for all members of the healthcare team. And it lays out fact and how to work in teams. And my intention was to create a playbook for the healthcare team, so we can talk in a similar language and better help the people that we're serving. There's a website by its name, Behavioral Basics of Behavior Change in Primary Care.com. Some free materials on there, so take a look. Some videos as well.
So to sum it up, Patrick, none of these guys have been sleeping since you saw them in 2019. This is amazing. I'm so proud of you. Oh, I'm so proud. There was something making a noise. I'm so proud of you guys for all the things that you're doing and all the varieties in the work that you're doing. It's beautiful. Just want to give a shout out to Johanna, Mrs. President. I call you that because you're president of the Swedish, I can't even say CBT Association, saying just, I really love this approach, being there and seeing the human in suffering instead of pathology. True that, sister. So I'm glad you're here, Mrs. President, and thank you for the work that you are doing for CBT in Sweden, and thank you for coming. Carl Jan is here from Sweden. Yay! Naomi is here. And here's a question from our good friend Francesca. Francesca is a student of mine, and she's from Italy, and she does amazing work in Finland. And she's actually going to come in here and do Cocktails and Courageous Conversation with me later on this year. And so Francesca is saying, for the Focus Act approach specifically, my question may be kind of generic, but I wonder how you can decide which processes to tackle at first and then make them come together in a single session. I mostly have trouble choosing which direction to go, especially in the beginning. What a beautiful question. You must get that a lot.
Hey, the fun of doing fact and act is I can dance whatever dance the person wants to dance. And in a conversation, you're going to go through multiple pass-bys of each pillar, right? So the good news is you don't have to worry where you start. You can just dive in, and it's not like you're in stasis. You're not jumping into a bin of concrete. You're jumping into a process. So what you do is going to stimulate another process, and it's probably more important to be able to recognize what behaviors are examples of. Like, when is somebody talking about acceptance-oriented issues, right? So learning to recognize in sentence structure and in the content, oh, that's an example of non-acceptance. That's an avoidance behavior.
Yep.
So I go over to openness. So we're going right now in the moment, I might just have a micro intervention, because in the whole model being rolled out in one session, we don't have to wait because you did in a non-committed action just now, but we haven't talked about commitment. We have to wait till session 4.
Yeah.
In the model, in the protocol.
Yeah.
All of that's out on the table, so you're just doing what you're doing as a client now, and I'm going to do what I'm going to do in response to what you're doing. So everything that I do is basically a probe. It's designed to kind of push you a little bit to see how you handle it and it's sort of, this is the behavior analytic feature of ACT, is, you manipulate the environment, which is the discussion with the client. And then you see what they do in response to the manipulation. And then this may be a moment of skill training, right? Discrimination training of whatever kind. So it actually isn't really that important that you pick the right pillar. You can pick any pillar you want. What's important is you got to watch how your action affects the client's behavior. In the immediate moment of your action will affect the client's action. And you need to be able to characterize what is the client's action an example of.
Yeah.
Right? So are they talking about values now? Are they talking about not being aware?
Yeah.
Did they just act like they didn't hear what you said?
Yeah.
And those are the things that people have to learn through just practice, repetition.
Yeah.
There's this book by Malcolm Gladwell. It's called Outliers.
Yeah.
I don't know if somebody's probably read it in this group. And his conclusion overall is to become a true expert, like a true at the top of the heap. You have to have 8,000 hours of exposure.
Yeah.
To
repetition.
To the topic. So he studies people like Bill Gates, and other people that are geniuses, and goes into their autobiographical history, and it turns out they always had opportunistic exposures to things that nobody else got.
Yeah.
Early on in their life, Bill Gates had access to old IBM computers because his father was a college professor.
Yep.
So he was able to hang out in a building for hours on end, learning about computers before computers became computers.
Yeah.
So I think I'm not saying you got to practice therapy for 8,000 hours, but I am saying
practice helps.
Practice helps, and if you sort of
and practice support tools, I think, and we do use those in fact. So just a very practical answer, Francisca, is we use the Foursquare tool, and we use the Pillars assessment tool and the Pillars intervention guide to help people kind of develop the skills they need to move in a more dynamic way, trying to influence psychological flexibility during the clinical conversation by the opportunity that's arising at that moment. So those tools are on that website that I mentioned a while ago. So you can take a look at them. A different way of working, consistent with the assumption Kirk was saying, we might only see them one time. Let's see what we can do, what we can move, what we can support, get into place at this moment in time. So take a look at those tools. I'll also mention that Kirk and I have done an online course with Praxis, which we're receiving really good feedback on in terms of people being able to kind of have the opportunity to look at videos and then re-look at them, listen to the comments, use the worksheets, and kind of develop that skill of just trusting your intuition about where to go, which pillar to work on, and letting it go. If it isn't working, heck, just go to a different one.
Yeah.
And remember, non-action is not possible with behavior.
Exactly.
So whatever you do, you're behaving.
Yep.
Right?
Yep.
So you might as well do something on purpose.
Yep.
And then let it roll.
Yep.
Right? And even being silent sometimes is a behavior of extreme importance.
Yep.
Right? Because silence tends to slow things down and elicit, present moment awareness more.
Yep.
So if you see yourself, you're always streaming in relationship to the client, then you don't have to worry about am I doing the right thing or the wrong thing, but how do I swim?
Yeah.
Right? In this stream.
Yep.
Because the stream has eddies in it. You move to the right and left, things kind of swirl around, and you just you have to know when to relax and let that happen.
Yeah.
And you learn. you know, when you kind of resist and push against something, you'll learn very quickly
Yep.
that you don't want to do that.
I love what you said there, like you can dance any dance, like, and I think like, so if whenever I would get this question, and I get asked the question a lot, like, where do you start? Like, and what process do you start with? And I think some of my students think that first you do acceptance, and then you do diffusion, and then like you follow that. And I'd say, so the metaphor I like to use for this is like, imagine going on a hike. And so you're going from A to B or whatever. You're going somewhere. And there's no way I could tell you, like, for the first 700 meters, there will be sun. After 700 meters, it is going to rain for 18 minutes. And after 18 minutes, you will then start to be, you'll have mosquitoes. Like, there's no way of predicting that. So what I say is like, you want to pack your backpack so that you have sunscreen and you have an umbrella and you have mosquito lotion or whatever you call it. And so your job is to notice as you walk, now I am being burnt by the sun. This is the time to put on sunscreen. Now it's raining. It's time to pull up your umbrella. So you want to pack your bag, and you're doing that by getting all of these skills in that we have in ACT and in focused ACT, which are the same. And so you want to listen to the process of storytelling rather than the stories in and of itself, right? And then I love what you're saying about dance or swim. There are many ways to talk about this. But so the way, which is what you guys taught me years ago, the way I find out where to go is that I first ask, like, where does the client want to go? And what's in their way? And how are they trying to solve that in ways that are not working for them? And can we come up with better ways, which is basically the 5 focus questions, or the basics of creative hopelessness as well. So if that was helpful, please take this with you as well. All right.
Yeah, I generally want people to do in session with me what they do out in life.
Yeah.
So I want them to do unworkable things in
Yeah.
front of me. It
Yeah.
isn't like you have to come in and perform and not
No.
make mistakes. I want you to do every move you do.
Yeah.
So I'm going to be instigating,
Yeah.
you know, poking, prodding,
Yeah.
and it's okay to let the thing unfold. That's sort of the behavior analytic,
Yeah.
you know, approach.
Yeah. All right. So thank you for all these beautiful questions. There's a time for a little more. Sarah is asking, how can practitioners best contribute to research, given that they want to focus on seeing clients?
I think I'll just take a stab at that, just a brief comment. One of the things about FACT is that it has built in questions that yield data that can help you evaluate your practice. And they're little metrics that are useful in the interview clinically, and useful in terms of evaluating your practice or describing the outcomes associated with your way of working. So I'll just list those very quickly. So the first is we have 3 rating scale questions that we ask in every visit. One has to do with the problem severity. That's an important measure because it tells us about the level of psychological distress for the person at that point in time, and psychological distress is associated with their staying with us and being engaged. When psychological distress drops, they're less likely to come back. So rating scale is 1, not a problem, 10, a very big problem. We're looking for problems 7 and above. Another rating scale question that you can use in a very pragmatic way, but also for research, has to do when we get to the point in the interview where we're moving into the design of a behavioral experiment. We actually write that down, have the person write it down, and then we say, that's the plan. on a scale of 1 to 10, how confident are you? 1, you're not sure you're going to do it, not confident. 10, confident that you'll do it, very confident. Confidence is associated with follow-through. Follow-through is associated with actually going out there and doing something different and seeing what happens. And then the last one is helpfulness. So helpfulness is associated with engagement, satisfaction with care, likelihood to return, whether for a visit next week or 3 years from now. So how satisfying, 1 not, or how helpful, 1 not helpful, 10 very helpful. So all of these metrics, we're looking for 7 and above. And then the other metric we have is very useful. It's in follow-up visits. We always ask the question, would you say the problem is same, better, or worse? So if you have a way of kind of describing problems, you could have research that says, I saw this kind of problem. It might be this person was here for stress, this problem was here for a relationship problem, broad categories. Then you can actually look at your data, your research, whether in your clinic, your network, and say, these are the outcomes we have for these patients with this type of problem. And these are this is our level of helpfulness to our patients or clients, and this is the level of engagement in their behavioral experiments. Yeah.
Wow. Thank you for answering that.
Yeah.
And thank you for asking that, Sarah. There's a hello from Lisa Coyne, Patty and Kirk. Lisa is here with us. Thank you for joining us, you wonderful human being. There's a greeting from Randy, our American soul sister in Norway is here. Ulrika is here. Tove, the president of ACBS Sweden, is his hands are making macaroni pudding while his ears and his heart is here with us. I know that Tor is at home with his daughter today. Taylor, you answered Taylor's question earlier. She says it's very clear. Hello, Ulrika. Happy to be here. Hello from Jönköping. Wow. Looking forward to reading the book. We're all looking forward to reading these books. Raul is here from, Raul, where is it that you are? I think it's Argentina or where is it? Oh, Raul, I know you're from somewhere around there.
A long way away.
Yeah. Raul. Loving the title, says Suzanne. Say the title again. Love.
Learning, loving, doing.
Learning, loving, doing. Love that. Thank you very much from Patrick. I might be a little behind because I'm like reading all the comments. Johanna says, the basics book, has it been translated?
No. To my knowledge, it has not been, but I'll put in a word for that.
Yeah.
Yep.
And we do know that our friend Thomas Gustafsson in Sweden is a huge resource when it comes to fact resources in Swedish. All right, here's one. Hello, Victoria. There's a question from Victoria. I'm just gonna check how many there are. This is the last. There's a lot of love for you. I just wanted to say that to you guys. There's a lot of love and hearts for you. Here is Victoria's question, and we want to be mindful about the time. Victoria says, some of my co-workers, CBT therapists, are skeptical to the procedure of having the nurse referring directly to a mental health professional because the client might experience that their issue, like stomach ache, heart beating fast, is not understood or being validated. Can you say something about that? And can you say something about that in 1 minute?
I think, I'm the 1 minute person.
I can't say anything in 1 minute.
I think
Can't say my name in 1 minute.
I think the way that I think we need to help in that way is to say that stress is always a factor in our health, and that maybe this the nurse can say maybe my colleague can help a bit with the stress of having this kind of problem, because it's not easy.
You nailed it, sister.
30 seconds.
Whew.
I could get up and do a rant.
Oh
now.
my God.
A 30-second rant.
All right.
No, but I won't.
Maybe dance.
So we're at the end of the hour. I know Kirk and Patty has been working so hard today here in Copenhagen, enjoying the sun and
The heat.
the heat.
The lack of good air conditioning.
And the lack of good air conditioning, and a beautiful group of people who are here with us being trained.
It's lovely.
So thank you so much for offering 1 hour of your time to come in here with this beautiful group of people who are watching either live or catching the replay. And thank you to everybody who's watching for giving us an hour of your time and your attention and coming in here. And much love to you
the
all.
Stardust Lounge.
To the Stardust Lounge. Exactly. Thank you for the impact you are doing. Thank you for the change that you are making in this world for yourself and the people that you serve. And a big cheers from me, Patty, and Kirk. We're now going to go order
Here's
some
you.
food, finish these cocktails, and keep having courageous conversations, aren't we? So much love to you all. Make sure, I'm going to show Kirk and Patty the comments later on. Make sure to send hearts and love and all the support that you can. And of course, I'll be back and tell you when these books are out. I will promote them like a crazy person in this group, because you deserve all the praise in the world. So thank you, Kirk, Patty. Thank you, everybody. We love you. Bye.